funny about what's going on right now. I mean, well, that's, you could laugh rather than you cry, with half the population as of Saturday morning heading into tier 2 or tier 3. Of course, Manchester still fighting to keep out of tier 3, but London and Essex, York, parts of Surrey, Cumbria and Derbyshire moving from tier 1 to tier 2 at midnight. That involves basically the rule of 6, 10 p.m. curfew, plus the ban on households mixing its indoors at home or in hospitality venues. And it's also expected that today that Lancashire and the North East could move from tier 2 to tier 3. Already bearing in mind the Northwest, Greater Manchester, West Midlands, North East and Lancashire already in tier 2. Everyone keeping up at the back there? Of course, one of the arguments we're getting at the moment is we need to move to a circuit breaker, a national circuit breaker. Well, 2 or 3 weeks is what Keir Starmer suggests. I'm telling you right now, it's not going to break the circuit, and it's not going to be 2 or 3 weeks. It's going to be months, because we know what that first 3-week lockdown was. Yeah, 3 months later. Well, we are looking at something that would, though the idea is to give us time to catch up, dampen the number of infections, dampen the number of deaths down, and give the country the time to sort out the test and trace system. Well, given the latest figures on test and trace came out yesterday, showed yet another record low, contact tracing down to 63%. It was 68% last week. But either way, that's simply not enough to actually have a meaningful, to a basic way of actually tracing enough people to keep infections down. I want to know, how can we actually improve this? Professor Allyson Pollock joins us now. She's a clinical professor of public health at Newcastle University. Good morning to you, Professor.
Good morning, Julia.
I think a lot of us, given that we know how many billions of pounds has been ploughed into this test and trace system, we know we've got highly paid consultants who've been on up to £7,000 a day for some periods of time trying to handle the setting up of this test and trace system. A lot of us are, ripping our hair out at the fact that it doesn't seem to be properly functioning in terms of not everyone being able to get tests. Big question marks about false positive rates, especially with the number of people we're testing. But the fact that even when we do say people testing positive, we're not tracing enough of the contacts to actually do the job of test and trace. What is going wrong, and how can it be fixed?
Well, what went wrong really started off in April with the government's testing strategy, really from March, because it decided to take testing out of health services. And if you think about it, Julia, you really can't get a test unless you go through a health professional in the NHS. And that's important, because a test is simply a tool to aid the diagnosis. It doesn't make a diagnosis. And especially a PCR test for the virus, because all it does is it tells you whether you've got a bit of the RNA virus, but it doesn't tell you whether you are currently infected, whether you have past infected, and most importantly, it doesn't tell you whether you are still infectious. So it really, the big mistake the government made was to make testing almost on demand and to take it out of health services. And what it should have been doing is building up primary care, building up the NHS labs, and asking them how testing should have been organised, and then integrating the testing back into the system. We have had a COVID-only service for many months, unfortunately, nearly COVID-only service, only doing emergency care for many months, and that's resulted in a big backlog. We cannot afford to have this continue. So testing needs to be less shambolic, it needs to be much more coordinated, and it needs to be much more strategic. We've been testing far too many people in an uncoordinated, unstrategic fashion, and that then results in us not being able to interpret the tests, contact tracing being overstretched, and us doing too much contact tracing and too much isolation as well. And
this is it. Isolation. Testing, particularly after all the kids went back to school, mass testing of children, because basically, your kid can't go back to school unless they've got a negative test, when we know those children are highly likely to be negative. And then students going back a couple of weeks later, and again we've had exactly the same thing. What a surprise we've seen this boost, not just in the number of tests that are positive, but also in the percentage, the proportion of tests that are positive. But as you just touched on there, it's a very big issue of the fact that most of these people who are testing positive don't have any symptoms. They're asymptomatic. They are unlikely to get any symptoms. They're not actually, many of them, or most of them, likely to be able to pass the infection on to anybody right now, because they haven't got a live infection themselves right now. And yet entire government policy, lockdown policies, tier 1, tier 2, 3, 3, all of these policies are being made based on this very rising infection rate, which will inevitably lead to hospitalizations and deaths and a second massive wave of the pandemic. Everything is being based on a testing regime which is highly questionable.
Well, I agree. I think the testing is really hard to interpret, which is why then you need to look at other indicators, and their hospital admissions, ICU cases, and deaths. Now, there's no doubt there's a rise in cases, especially among young people. As you rightly say, they've gone back to university and they've been doing more mixing. But the big problem is when you start to screen healthy, well students who don't have any symptoms, and you get into very big problems over the interpretation. And screening is a very complex intervention. We should not be doing it unless we've carefully piloted and evaluated it, and we haven't. And so universities shouldn't be doing it. So turning to the hospital admissions, our thresholds for admissions are very different from what they were in March and April, and so are our treatment regimes. So if you think about March and April, we weren't admitting many old people. People in care homes were dying in care homes, and people at home were dying at home. They were not getting into hospital either because they weren't reporting themselves admitting or being admitted. So we have a very different threshold for hospital admission and also ICU admissions. If you're on ICU, it doesn't mean you're on a ventilator. Everybody always thinks they are. So we need to understand these data much more, and we also need to look at the death data. There is no doubt that there is a rise in cases and admissions, but
as
it's
you
not
would expect.
as serious. But you would also expect more background immunity now in the population, and that's what we're seeing in some parts of London, which had a lot of the virus and then lockdown after the peak of their epidemic outbreaks. Then they're not seeing nearly as much. And what we're probably seeing now is regional cases in regions where there wasn't so much virus before, and or where it hadn't reached its peak and it's circulating.
Exactly. So in that sense, it's not a second wave. It's they haven't had part of the first wave, but we've got so many better treatments now. Fewer than 15% of patients who go into hospital with COVID now die. At one point, it was 50-50 whether you came out of ICU alive or not. And this thing, we do know so much more. And World Health Organization published a document day before yesterday, a new study which showed, and it's peer reviewed, it's very much a kosher study showing that the death rate from coronavirus for those who are under 70 is 0.05%, and that means for under 70-year-olds, healthy under 70-year-olds, it is a lower death rate than flu. Now it is absolutely a deadly disease for those who are very vulnerable, infirm, and who are elderly, but it is not for the vast majority of us.
I think that's right. The vast majority of people will get better, and what we need to do is to make sure we've got proper services in place so hospitals can cope. We should have been expanding capacity in primary care and in the NHS labs, and instead of spending tens of billions of pounds on ineffective privatized services that have never run these services before, like Serco, Citol, Deloitte, Amazon, we should be putting it back into the NHS, and we should be using the operational know-how and expertise of people who understand the epidemiology of communicable disease control and the operational parts of communicable disease control. And that's where the government has gone so badly wrong.
Okay. And do you think that if we had this so-called circuit break, that we had 2 or 3 weeks, who are we kidding, it ended up being a lot longer, that would be time for the government to fix their test and trace system?
Well, this is a political decision, just as it was a political decision to privatize. There's so much politicization of what we should and shouldn't do. But what we really need is a public debate and so that the public are allowed to understand what actually cases and the triggers for this lockdown are, whether it's cases, whether it's hospital admissions, whether it's deaths, and the public need to be given this information so we can be involved in these decisions instead of this complete politicization that's going on at the moment.